Public health. It's a huge topic. You could probably fit all of these 10 into this topic. And let me just begin by giving you a number. 0.02. This is the number of doctors you have per 1,000 people in the Southern African country of Lesotho. And I have intentionally mentioned a developing country because we need to be fair. We have to admit that this is our primary concern in a global sense. There are lots of problems in developing countries, but a large factor that plays is the lack of resources. You have lack of human resources on one hand. You don't have enough doctors. You don't have enough nurses, midwives. And on the other hand, you have the problems with the natural resources and the distribution of the medicine that we send down there, and also the infrastructure. The lack of infrastructure is a huge problem, especially in respect to the distribution of medicine. So what we've tried to do is we have devised a hierarchical system which is focused on efficiency. Now, let me just elaborate real quickly. So you have 3 levels. You have the local level, which is you have your local medicine man in the village or a town anywhere in the world, which just provides the basic healthcare, and basic healthcare is also somewhat of a definition that we cannot just make for any country. But just imagine you get the simple provisions from this from this medicine man. For example, if you get a headache and you need aspirin, it's just like you get it from him. Then if that is not enough, and in most cases, especially in the developing countries with the tropical disease, it's enough to just get the medicine from your local doctor. But if that is not enough, we go one step down or up, whatever you prefer, and we come to the district-based level of the state-run hospitals. There, most diseases are treated, and unless it falls into the 3rd category of the special clinics, which it depends where how many you need of those, but they specialize on one thing and they do it right. There are 2 questions. How do you provide these resources? The first thing we need is an efficient education system, which would be made on based on modern standards, modern curriculum, and focused on a practical formation of the staff. You need to get involved with the local population of these rural areas, sometimes hardly accessible areas, and you need to ensure that the people stay there and do not get exported in a way, the way we do it right now, the way we get our medical staff from all over the world. And it should be focused on practical formation due to the fact that there's often no need to have a doctor with a master's degree in those areas, but rather someone who just knows what they're doing on a basic level. And the prerequisite for this system is an efficient administration. So you need to have a centralized sort of a governing body which set up the curriculum for the education and which would regulate the distribution and effective healthcare. And we also need to be innovative. It doesn't matter whether it's in the Western world or the developing countries. We need to digitalize the system. We need to fully transfer all the paperwork to computers. We need to set up databases, and this is also where you see that this system can apply to the Western world. We also have the problem of a high administrative cost, and for that I will just give you an example. So what's that?
I mean, this is the situation today. We've got paperwork, especially in Western education, public healthcare systems. We've got lots of paperwork in administration. Paper is heavy. Paper gets lost. We live in the 21st century, and for that, we've got other solutions. So digitalization of the whole healthcare system, especially in Western societies, has to be one of the main goals. Because here in Switzerland, we don't care about having enough distribution of doctors. We already have that. We have to cut costs. And one way to cut costs is to digitalize the whole administration. Digitalization should but also go in another direction. We propose the creation of a centralized database where every doctor, every hospital, every research facility has access to, be it in an anonymous way to do research, or be it just in a personalized way so they can treat their patients more efficiently. This is one side, to cut the costs, but on the other hand, we got to know where the money comes from. We're talking about the financiation of the whole system. And for that, we have focused only on those countries who already have a functioning public healthcare system, and we provided a financing plan or a financing model which is based on this triangle here. We've got public health care, which is based on a mandatory insurance with progressive fees. So you've got the solidarity aspect in it. Rich people pay more on that basic healthcare model. Then you got the private insurance. And I'll explain you later why we have made this division. Third is self-responsibility. We have agreed upon that every one of us should be concerned about their own health. But to start with, we have here just the basic health care. So there are no luxuries in it. You don't get a single room if you got that model. You don't get a dental insurance if you have that. If you want your eyes getting lasered, not included. We just say basic insurance. You get generic drugs if there are any available, no brand drugs. If there are no generic drugs, we would have to discuss that. But as you see now, we had some problems in defining basic, and because of that, we changed the approach. We just said, let every one of us decide what basic is. Give every one of us the choice to just opt out of certain insurances which are included in there. We could, for example, would have a decrease in the insurance rate if you get vaccination on a certain degree, on certain diseases. If you say birth planning, this is my option, I don't want to pay for abortion, okay, opt out of that, but if you want to have an abortion, you don't get paid. You say sexual transmittable diseases, I can care for myself, I can protect myself. You can opt out of that insurance, but if you get some, you've got to pay for yourself. In addition to that, if you want to have more luxury, if you want to have massage paid, if you want to have your eyes lasered because you're sick of your glasses, if you always want to have access to brand drugs, get your private insurance. Get your private insurance if you want to be sure that your children always have dental costs covered. Here we propose a free market model. Let insurers just offer what they want. People may buy it, people may not. The third part is self-responsibility. We want to have incentives to cut costs, so not everyone runs to the doctor every time. For that, we propose that you and I, everyone pays 20% of the health insurance costs you cause, but because we don't want to be held to sickness, meaning poverty, we say if this costs rise over 10%, the state pays the rest. So sickness doesn't mean poverty. In addition to that, we say that if you just go to the doctor, you have to pay a certain amount, like 20 francs in Switzerland. And we go even further, we propose a fat tax. So you've got a consumption tax on every unhealthy food. You still can buy 10 Big Macs a day and eat them, but you know, with the tax, you pay some part of the negative effects of an unhealthy lifestyle. With this triangle model, we are convinced that you can cut costs efficiently and also guarantee a long-term financiation of public health care in Western societies. Thank you.